Hi, everyone. Welcome. So good to see you all here.
Thanks. So good to be here.
We saw many of you at the summit. Uh, Gosh, when that feels like ages ago, but I think it was only a week ago. And then also the health for those of you who joined us at health too. My voice is going. I think I was a product of Las Vegas. But we're really happy to have you here, as well as having our guest speaker from Alameda today. We'll give a few more moments for folks to join. Angie, just let me know when you see this, we can get going. Exactly, Jim. If you can go ahead and introduce yourself on the chat, that's our way of making sure that you are able to connect with others, not only here, but also outside of these calls, which I know really yields lots of good conversations. So please introduce yourself, your organization. Let's use the chat today as much as possible. All right, let's get started. Angie, if you can go to the next slide. Super, we have a packed agenda for you today, as always. I will spend just a few minutes with us talking about the summit. I would love to gather your insights. Oops. I would love to gather your insights so that we can do an after action report and make sure that we're capturing all of the golden nuggets for those of you that were there. And then also we then will move to the guest presentation, which is the Alameda SHE and the Community Health Record, the social health information exchange. There's been just so many conversations that we've had over the last 6 months about community information exchange. We're seeing a lot of RFPs from counties that are exploring something similar. So I thought it would be great for us to get grounded on what Alameda is up to. And then we'll move into the legislative updates. We have lots to cover around the data sharing framework and policies and procedures. And our own Olivia will walk us through that. Robbie is on vacation this week. And then we'll move into news and events. And as always, if you have any other announcements or news and events, please use the chat. And we would be happy to share them in our newsletter that should be in your inbox this week. So moving on, let's move to the coalition. If you're new to the coalition, we are a multi-stakeholder organization here together to advance data sharing in the state. We have policy priorities that we refresh every year, clearly focused on the data sharing agreement and education around making sure that those of us are aware of it, our peers are aware of it, and it's getting signed. We also want to make sure that we have the right funding available and in place to be able to do the necessary build of the infrastructure. Our focus also as Californians, where we are tackling social services as part of our aim for healthy Californians, I think are a little different than the rest of the crowd across the country, and including social services in our framework. And finally, as we will be doing today, reviewing and making sure that we are contributing to the development of the data sharing agreement and the policies and procedures. We will look forward over the next few months, refreshing these priorities as we look to the new year. And if you didn't catch the announcement that I made at the summit, Connecting for Better Health filed for not-for-profit status last week, or I'm sorry, 2 weeks now, that's been approved by the Secretary of State. So please reach out to me if you want to be part of our building blocks as we move forward with the building the not-for-profit. We'll be seating a board as well as an advisory board. And I can't wait. I think the sky's the limit. So thank you. Thank all of you for getting us to this next stage in our growth. So let's go to the next slide. Thank you. So this is also just to make sure that this is on your list of things to do. We are awaiting the publishing of our consent white paper that we authored with our friends and our partners, Stewards of Change. If you missed it, we had our first of a 4-part webinar series on the Ask Me pilot. The Ask Me pilot is a pilot to address consent and to test out a uniform consent form for DHCS. It was quite successful, and hopefully we can put the link in the chat of the webinar recording. Our next one is going to be focused on the SHE, and if I don't know, I'm sorry, SHE, which is the SHIG. This is the SHE is today. The SHIG is what we're going to be focused on with this webinar. The SHIG, we love our acronyms, is the State Health Information Guidance that is such a gift for all of us in the state. And I just don't think that we've lifted it up enough for us to be able to really focus on it being a resource. So we'll be looking at both not only the state of the SHIG here in this webinar, but also what's the way forward and how do we update it going forward, but given the data sharing framework, as well as the work that we're doing in consent. And now we're moving to the debriefing. I think there's another slide here to give us a visual. So thank you again for all of you who attended. It was a really packed 2 days. We opened it on Wednesday evening with a reception, and then we had an all-day programming on Thursday and then a half-day programming on Friday. I just want to get us kicked off with a thank you to our partners, with Manifest Medics, with CDII, the Center for Data Insights and Innovation, and also the California Healthcare Foundation, that I think really pulled together a very robust and meaningful conversation. And after over the last week or so, I think the headlines was that it was very honest, that we really were able to tackle issues, and I'd love to talk to them about here today, what you thought were the really kind of key big nuggets going forward. And I also think that in addition to being honest, it was a little spicy. We weren't afraid to be able to ask some of these big, bold questions of some of the big missing, I guess, building blocks of the data sharing framework, and what we're seeing as those that are early adopters versus those that are on the sidelines. So personally, just to get us kicked off on this conversation, I think the storytelling that we had as part of the programming, we had 2 sessions that were formatted as TED Talks. And one of the ones that really stuck out for me was the Marin. We had Lisa Santora from Marin County, who I actually know and just admire, and the work that she did to be able to help households, a whole apartment family who was displaced during the floods that we had here in Marin County, and how broken being able to respond to a crisis our systems are, not only for individuals, but for households. And this concept of households that I think we all need to keep and hold in our work going forward. And then also on the other side of the continuum of being a California healthcare worker with a CHW and a social worker, of how broken our system is when we have folks who show up to be able to help with their services, and the confusion that happens when it's not coordinated and 5 meals are being delivered at a time. So both of those really, really spoke to me. And Jim, let's go with your takeaway.
Well, thank you very much. I just want to add real quick that to your point, and it's an excellent one, there are also some initiatives in California and with us at the Michigan Health Information Network about better incorporation of data from the HIEs and from data exchange into EMS, so that when EMS shows up at a crisis in a situation, they're better afforded information. I think as I look back on it now, that's something that's kind of left out of the DXF, but it's a critical building block. And your example of the floods is a great one.
Well, thank you. And we had EMS also present. So they're there, but I think you're right. Like, that was the other big takeaway, is how critical these organizations, including EMS and county services, both on social and behavioral health services, that are not required to sign. And so it was not only the what the state is doing to be able to bring these very key state stakeholders to the table, but acknowledging that that is such a missing piece. And then moving, I'm just the other kind of key takeaway that I wanted to relay was this idea of, in communities, who's on first? Who's really going to stand up and be the individual or the individual organization that's going to orchestrate this data sharing framework in the community to make it work? And I think we even had a really great conversation at Civitas get together of health that focused on this idea of community governance, and where do we have a public-private governance model, which I think we'll hear about today from Jennifer with Alameda. But when you do bring this amazing information together, how then do you use it to benefit the community versus it being, isolated in silos? So those were kind of my takeaways. I'm looking at folks that are here today that were also attended the summit. Feel free to add on if you can. Just looking, Jim, you were there, Jim Hickman.
Yeah, and to me, I'm not going to name the county I was on a call with this morning, but having a county conversation about where they think they sit in California data exchange and CalAIM implementation is, there's a lot of room for level setting, right? And I think that's where we left our conversation at the summit, where if there's no one on first, then everyone's going to play whatever game they feel like playing rather than a real collective effort to bring this model together. So couldn't underline your point more.
Well, thank you. And I think that brings maybe to light, as we think about priority setting for the coalition next year, that this idea of public-private partnerships at the community level really needs to be something we focus on. Dan, you're off camera. You're on camera.
I am. Good morning, all. Couldn't agree with more with all the previous comments. I think what was great about this summit was the inclusivity. To the point, Timmy, this is a community effort. Everyone's got to be at the table. That's kind of hard. The table's got to be big, but it really is that sense of inclusivity. Yes, someone's got to take leadership. Someone's got to start. That first domino has to fall, and the other domino's got to be ready to fall right after that first one falls. I think what was unique, and back to the sort of the spice, I guess I'll focus on your spice. This was the first conference where a major part of the ecosystem was booed openly and verbally, which we all got a chuckle. But by the same token, I've never been to a conference where that has occurred, where the audience kind of was really rallying, if you will, in the sports metaphor, to have this part of the ecosystem be part of what was going on here.
And that happened to be on my panel, by the way.
I wasn't pointing that out to me.
No, but it was I thought my panel that we included, for those of you who didn't see it, it included UCSF, Sutter, and LA Care. And it was just a really great, honest conversation of why UCSF, including the other UCs, I don't think the answer wasn't why, but the acknowledgement that the UCs hadn't signed the data sharing agreement. And I also thought from Sutter too that there was some being an early adopter, super articulate as to why. And then what came out too from LA Care is all the work that's going on in investment that's happening at the plan level to be ready to be able to meet the data sharing framework needs. So yes, Dan.
The Sutter physician was memorial, truly. I took down quotes from, and I'm sorry, the doctor's name isn't fresh off the top of my lips here, but that was just incredible. Yeah, he was just incredible.
Yeah, we'll have to have him come and be a guest here. Well, I think there's more to be done from this work, and I will be reaching out to many of you to help with, I think we should put a roundup, a wrap up or a summary to be able to make sure that we're capturing those key points and that we really kind of hold it dear as we are thinking forward. One thing that we haven't tackled here, I just want to add, and happy to talk to anyone about it after this call or when we get together next, but also kicking off the meeting with Lisa Bari, moderating a session, both with our own Marco and Mickey Tripathi. That also is a real big highlight. And I also showed the need for coordination among ON at the federal level with ONC, with the work that we're doing here in California. And I was able to have my own side conversation with Mickey on that. So we're making inroads there too. Okay, so moving us along. Thank you yes, Jim. Oh, you're on mute.
Was that session taped with Mickey and Marco?
Nothing was taped.
Oh,
and
any good note takers in the crowd? Because that was a really illuminating conversation. So
I have a lot, Jim, so I can type up what I captured and send them on over to you.
Or to I think everyone here, honestly.
Here we could make a formal blog on that and have them both okay it. And plus I have we have their slides. So yes, we will do that. Thank you. Thank you for the exclamation point on that. So moving us on, I would love to introduce to everyone Jennifer Wong, who is leading the charge in Alameda County. They have been working diligently on their community health record as well as their social health information exchange. And I think their unique approach is something that we can all learn from. And it also is representative of has grown to be known as a very critical component of our CalAIM work in Alameda. And Blue Path is the CalAIM Path facilitator in Alameda. So I couldn't be more excited to be able to work with Jennifer and her team on making sure that we meet the CalAIM needs through the work that they're doing. So Jennifer, we're going to have you go through kind of the why and the what, and then we'll have some time for some questions.
Yeah, no, thank you for inviting me today and letting me talk about the data sharing tools that Alameda County has created. Olivia and Timmy, one asked if you don't mind monitoring the chat in case questions come up. That would be...
I'm on it.
Oh, awesome. Thanks. Great. Next slide. Great. So I'm here to talk about the Social Health Information Exchange, how it came to be and how it's being used today. And again, my name is Jennifer Wong, and I'm the engagement manager for the Community Health Record, which is one of the main data sharing tools that's used by providers in Alameda County today. So the vision behind the Social Health Information Exchange, or the SHE, came about during the Whole Person Care pilots, which was the predecessor to CalAIM. And as many of you will remember, the main goal of Whole Person Care was to improve coordination between physical health, mental health, and social services providers. And our leadership saw that it was really hard, and it sounds like everyone on this call experiences that it still continues to be really hard to share information across these very siloed care sectors. But our county took a stance and created the SHE to bring together information from different care sectors that have been siloed in order to better understand a consumer's as well as the population's care needs from a whole person perspective. And the SHE securely integrates data from multiple systems of care, such as medical, mental health, substance use, housing, social services, justice, and crisis. And this current slide visualizes the different things that went and go into making the SHE what it is, as well as the different ways our partners get information out of the SHE. In terms of what the different inputs that go into the SHE, we currently have 21 data sources that actually comprise about 30 different data feeds. We also have a data governance structure in place that includes execution of an identical data sharing agreement by all partners who send and or receive data from the SHE. We also have multiple data privacy and security structures in place to redisclose information according to all applicable state and federal guidelines. And we also have record matching capabilities, meaning we can tell whether a Jennifer Wong from one data feed is the same Jennifer Wong from another data feed is the same as a Jenny Wong from another data feed. And this record matching capability is actually pretty critical to the applications that utilize the SHE data. And in terms of how partner organizations can get information out of the SHE, there are really two main categories of outputs. The first is we have various analytics outputs that we can provide, including custom reports, dashboards, visualizations. For example, something that we've been doing for the past few months is we've been sending a population level file to our health plan partners in Alameda County that essentially lists their entire membership, as well as includes indicators on which members are dealing with homelessness as well as incarceration. And the second way that our partners can get information out of the SHE is through a number of provider-facing applications that utilize SHE data. So we have one application that supports finance reconciliation for CalAIM providers. We have a scheduling platform for behavioral health appointments in Santa Rita Jail, which is our local county jail in Alameda. And finally, our most used platform for care coordination, the Community Health Record, or CHR, which acts as a window into the SHE, which allows users to see identifiable client level information on the consumers that they work with. And we use the term consumer to be encompassing of the term patient, member, client. Next slide. So this slide shows the different 21 data feeds that are data sources that flow into the SHE. I'm not going to go over every single one, but I did wanted to point out. So we have healthcare data from most of the major health systems in Alameda County. We get managed care plan information. So we have health information covered, but we also really were intentional to get social information as well as behavioral health information as well. So we have housing data from the homeless management information system that all of the housing providers in Alameda County use to document housing services. We have behavioral health information, and we also have public benefits information from social services, as well as Santa Rita Jail. And I also wanted to point out, as one of our crisis feeds, we actually are connected to ESO, which our county emergency response providers use as well. Next slide. Thank you. And so I wanted to use this slide to visualize the difference between the SHE and the CHR, because often the two get conflated. So think of the SHE. The SHE is the database that houses all of the data that we receive from all of the sources that we have direct connections to. So the SHE is that kind of entire iceberg, whereas the CHR, it's the web-based application that displays curated and actionable information for care team members who provide care. So the CHR is really just the tip of the iceberg in terms of all of the data that Alameda County has. Next slide. And in terms of some numbers on the community health record, right now we have over 910,000 consumer records that can be pulled up in the CHR. So these records represent consumers who are on Alameda County Medi-Cal, who are uninsured, or receiving other services from Alameda County safety net providers. And in terms of who's using the tool to date, right now the CHR is being used by 56 organizations in Alameda County across 255 programs. And we currently have almost 1,300 staff members across those organizations who have access to the CHR. We've actually trained well over 2,100 people to get access to the tool, but given kind of the level of attrition, people leaving the organization, about 1,300 are currently still at the organization. And the CHR if you don't mind going back one slide. Thanks. The CHR is currently utilized by case managers, clinicians, social workers, and other care team members from your traditional HIPAA covered entities. But something that our leadership really wanted to incorporate as well is allowing access to the CHR for non-HIPAA covered entities like housing providers, senior service organizations, and CBOs, so that they can have access to that rich clinical data in the CHR as long as they meet certain privacy and security standards, which enables that true cross-sector collaboration. Next slide. And so since the SHE and the CHR contain a lot of sensitive protected health information, we have an entire data privacy framework in place to make sure that that information is secure and protected. So there's a few different layers of rules that dictate which consumers and end user can see when they log into the CHR, as well as what particular pieces of information can be seen for a consumer. And access is determined primarily by three things. One, something called attribution. We have some rules mapped to consumer consent, and we also have varying permission levels based on your user role within the CHR. And I'm going to focus on attribution and consent. Next slide. So when we use the term attribution, that term essentially means kind of which consumers would your providers be able to see in the CHR, or essentially what consumers your organization has a care relationship with. So the way that the CHR works is not everyone has access to pull up records for that 910,000 people. So we use that 910,000 consumer lives as our starting pool, and then we attribute those members to what's called an operational enterprise to determine which consumers you can see information on. And so there are two ways that consumers are potentially searchable. One is through data feeds coming into the SHE. So if a data feed indicates your organization as a known care provider, it would attribute that person into your operational enterprise in the CHR. Or if one of your staff members knows the correct combination of first name, last name, gender, and date of birth, you can do something called self-attribute that consumer to your enterprise. Where this self-attribution piece comes into play is, say your organization gets a referral for a new consumer that your organization has no service history with, but you want to do an intake and get as much information that you can so that you can create a care plan. If you have that right combination of, again, first name, last name, gender, and date of birth, you can input that information into the system. And if that combination is correct, it would unlock that person's record in the CHR for you. And then I also wanted to touch on the importance of consumer consent. And the way that we collect consumer consent for the SHE and the CHR is through something that we developed called the Information Sharing Authorization, or the ISA. So the ISA was developed with lots of input from legal teams across the different care sectors that we get data on, and also created with consumer input. And it has special permissions for sharing of mental health information and HIV test result information. So those are actually two checkboxes on this ISA form. And the ISA essentially acts as a mechanism to redisclose or unlock information in the CHR to provide for even more data sharing. The ISA is of particular importance to those non-HIPAA covered entities that I talked about, because the non-HIPAA covered entities need to have an ISA signed in order to view any information in a consumer's record. But the ISA also does have some advantages for HIPAA covered entities as well, which I'll talk about in the next slide. But only one ISA is needed across the system. So for example, if your consumer is also a patient at Alameda Health System, and Alameda Health System was able to get an ISA signed and uploaded into the system, that single ISA will unlock that consumer's record to everyone else who shares that patient. So the ISA really is a lift all boats type model in terms of data sharing. Oh, and I see a question. What is the range of agreement to the ISA just in general? Timmy, are we okay to take questions now, or should we save them to the end?
Sorry, I'm unmuted. I was on mute. Go for it.
Christopher, do you mind asking your question?
Not at all. I'm just curious as to, what people think when they're presented with this, how likely they are to agree. Is it most people or very few?
No, that's a great question. And to be honest, getting the ISA signed has there are a few challenges with the ISA. I think for healthcare and even now housing providers in Alameda County, they're moving away from an explicit consent model to an informed consent model to try to kind of streamline the administrative burden on consumers signing a document. So that kind of eliminates an opportunity to present the ISA. There are organizations that have been really successful at getting the ISA signed when they incorporate it into their intake packet for new clients. There's actually an organization that has someone who actually runs reports that we've built into the CHR to see when an ISA is expiring, and is able to actually go out and work with the case managers to get the client to re-sign the ISA. But I feel like the ISA has posed some challenges that we are still working through. I think one of the things that I was surprised about is sometimes when you I've heard from some of our partners when you ask a consumer about HIV, even if they don't have HIV, it kind of freaks them out a little bit, and so it kind of creates some hesitation for them to sign. But for the organizations that have seen success, they really emphasize kind of how this document and how data sharing really helps them, and really kind of emphasize what's in it for them in terms of being able to serve them better, less duplication of services. But consent is a challenge, something that we continue to struggle with.
And Jennifer and Christopher, I'll just add that in the Ask Me pilot that was just done, where they were testing an informed consent that included behavioral health and substance use, it was over 80% pretty much across the board in all 3 programs or projects of individual signing. So we can follow up on that too.
Interesting. In my experience, one of the things that makes the biggest difference is how confident the person presenting it is. If you feel at all spooked about asking about HIV or substance abuse, that gets communicated, and then people don't want to do it.
Right.
Yeah. And I think that'll. Oh,
go ahead.
I was gonna say, I think that also speaks to the relationship aspect, and especially a lot of the people who have the ability to get an ISA signed are care coordinators or housing navigators who aren't always thinking about data exchange. And so I think part of it is also our role. How do we educate those frontline staff to be comfortable in talking about data sharing to really support their clients? Because really to them, this is an entirely new world to them.
I'm just watching the time, Jennifer, if we can.
Oh, yay. And then, so these next 2 slides kind of show the information that are shared before and after a consent is signed. So if you are a HIPAA covered entity, because of the treatment, payment, and operations clause, HIPAA covered entities can already see a lot of information such as demographics, care team member information, coverage information, clinical information, including programs, providers, medications, diagnoses, as well as housing and incarceration information. But even for HIPAA covered entities, what you can see after an ISA is signed is the social services enrollment information like CalWORKS, CalFresh, HIV test results, and also access to detailed hospital discharge summaries. Next slide. And then this slide shows the difference between what a non-HIPAA covered entity can see. So a non-HIPAA covered entity can't see anything without an ISA sign. So again, that ISA is critical to non-HIPAA covered entities' experience with the CHR. Next slide. Okay. And so this slide, I just wanted to give a few examples of how the CHR has been used to support care coordination. So by far, locating consumers has been the biggest value add that we've heard from our users. The CHR has the ability to tell whether someone has gone to the hospital or whether someone's been booked in Santa Rita jail. And there are also alerts that trigger in the system as well. And this has been really helpful if your program has a need to know where your consumers are at all times, or if your consumer goes missing, or if you're trying to get in contact with them to enroll them into services. It's been really helpful for streamlining information gathering at intake because the CHR creates a holistic and longitudinal record to support identifying what services someone might need. And lastly, there are collaboration tools built within the CHR, including a secure messaging feature as well as a shared care plan feature. Next slide. And this is for my last slide. I wanted to talk about the SHE in relation to health information exchange as well as community information exchange. So the SHE started with HIE at its core and integrated elements of CIE. We also leveraged the common features of a robust governance structure as well as data security and to really create a unique model in Alameda County that's both a data sharing model as well as a care coordination model to serve community members in Alameda County. And this is a ever evolving tool, especially as we try to focus on integration and interoperability, because we are still working with organizations and care sectors that are heavily siloed. But this is a work in progress, and it's already been successful in serving our community members to date. And we're looking forward to seeing how it can continue to serve our community members in the future. And that's it for me.
Thank you so much, Jennifer. That was just so well laid out in such a clear way. I'm sure everybody would agree with that. Yes, thanks, Dan. Any other, I'll do one last question before we move on. Okay. All right. Well, I'm sure, Jennifer, you're available for additional questions. The governance model, it links to the conversation we had earlier around having local governance and local purview over the work that you're doing. And then, being able to be that kind of, I don't know what the term is, traffic cop, but an accountability, somebody who's accountable for ensuring that those that we're losing through the cracks, that, that you're lifting it up and getting this help that they deserve. So thank you. Thank you so much.
And I'll drop my name in the chat.
Super.
Thanks.
All right, Olivia, I'm going to hand it over to you for the ledge updates.
Perfect. Hi, everyone. We have a lot to get through, so I'll try to be brief. So as you all know, the legislative session has ended, and Governor Newsom now has until October 14th to sign bills. Of all the many bills we've been tracking, 3 of them did pass the state legislature, and 2 have been signed, but 1 was vetoed, SB 582. And SB 582 would have prompted the creation of DXF standards for EHR vendors, along with a few other additional standards, like requiring the DXF to align with the 21st Century CARES Act, info blocking standards. And in the veto notice that will drop in the chat, Governor Newsom did call out that they thought that SB 582 was a bit premature at this time. And would prefer for the state to continue with implementation before considering additional modifications to the bill. But I'll pause here for a quick moment. Did anyone have any questions or want to discuss any of these bills further before we move into some of our DXF updates? Not hearing anything, so I'll continue on. But if anything comes up, feel free to reach out to us. And now moving into the data exchange framework updates, there's been a lot of activity in the last couple of weeks, and we've been very excited to track it all. Starting with our grant update, round three of the grants is going to open up on October 16th, and we expect the anticipated deadline for that to be December 15th. But funds can run out, so we do encourage people to apply early. In alignment with round 3 opening up soon, the round 1 and round 2 awardees have been announced. So we have some slides on the round 2 awardees, the appendix. And we are aware that CDII is still reviewing a few additional round 2 applications, so there might be more to come. And so far, $8.6 million in grants has been awarded to roughly 120 signatories. And we did want to call out too that umbrella grants are an opportunity for organizations to apply for funds together. which can be an opportunity for local data sharing partners to coordinate implementation activities and get on the same page. So definitely reach out to Connecting for Better Health if you're interested in participating in an umbrella application. And going on to our next slide, we did want to touch base with what's next with the QHIOs. We have heard that CDII has received 10 QHIO applications, and we expect that they will be announced within the next couple weeks, ideally in alignment with the round 3 grant funding opportunity opening up. They have acknowledged that, or they are planning to feature the QHIOs that are announced at an upcoming DXF Information is Power webinar. And there is one taking place on November 7th. So we expect that's probably where we'll be hearing more information there. And once the QHIOs are announced, CDII is going to convene everyone, and they're all going to begin working together to develop a work plan for 2024 to coordinate activities and prepare to exchange data. So let me pause here for a second again before we start digging into the policies and procedures. Any questions or updates that people want to share about the grants or the QHIOs?
Just to confirm, Jen, so there were 10 applicants for QHIOs, or they're only considering 10 out of the total pool of applicants?
The first, there have been 10 applications, and there could then be up to 10 QHIOs, but we'll have to see.
Got it. Okay.
I thought just one thing I'm going to share with this group, because it struck me, is that my conversation with Mickey Tripathi around the QHIOs, I use the term a QHIO network, this idea of a network of networks. And Mickey said to me, why do you keep saying a QHIO network? They're QHIOs. Yet the QHIOs are required to connect to each other. So I think it's something that we need to be a lot more vocal about, that if indeed the QHIOs are going to be interoperable and working together, that there is this notion of a network. And I could be wrong, but I thought that that was really telltale with my sidebar conversation with Mickey.
Timmy, I'll be willing to be that person in the peanut gallery that speaks up and says maybe that's a lack of understanding of the DXF by ONC.
Perhaps an opportunity to do more liaison and education.
And Timmy, I'll just reinforce, as an HIO that's expecting to be a QHIO, without question, this will be a network.
Thank you. Thank you for putting me on solid ground, Dan.
Yeah,
but I think it's an opportunity for us to follow up with ONC.
Yeah, and to that extent, I guess just give them a base, maybe to understand and baseline what their understanding is, and whether it's, without publicly offering fault to Mickey, if they really understand the legislation and the California-centric nature of information exchange it's supposed to be focused on. To Dan's point very well, of course it'll be a network, because somebody in Alameda has to get data from somebody in Santa Cruz so I can go to San Diego, and that's a network effect, but ONC just may not be paying attention.
Yeah, thank you.
Well, excited for more to
Olivia.
come on that. Yeah, no, back into PMPs. CDI has been very busy, and they are reviewing all of the previously published policies and procedures to ensure consistency, address concerns that have been raised, and to make clarifications to support implementation. So they do anticipate to release a number of proposed PMP amendments in Q4 2023. And here's the list of currently what is coming up and what's currently under development. We're going to discuss the comments for public input that were received for public input that were submitted in September. And we do hope to have a more group discussion around the participant directory at a future meeting. And first, let's get into the administrative modification coming up for the Individual Access Services PMP. The intention of these administrative modifications is not to change the interpretation of the PMP or expectations that are set forth for participants. And the modifications mostly are to be consistent with the DXF glossary of defined terms and to clarify some areas. And in general, or not in general, Connecting for Better Health has reviewed all the proposed modifications, and we do agree with the updates. So there is an online form, which you can see I've included a screenshot here. There are only like 7 main sets of questions in relation to each modification, where organizations can say whether they agree or disagree that it is administrative change. Connecting for Better Health agrees with these updates, and we are planning to submit comments via this online form that we'll drop the link in the chat. We do encourage others to review and submit your own comments, and let us know if anything looks a little funky to you, and we'd be very open to having conversations if people are questioning if certain things may be more than administrative change.
So call to action for all of you, the links in the chat. Thank you, Olivia.
Thank you. And yeah, I just wanted to note too that the objections are due by October 23rd, so they are coming up soon. And here's a quick summary of what those revisions are. They've removed the definition section of this PMP, and instead note that all the capitalized terms are in the glossary, which is consistent with what all the other PMPs are being updated to include. They're switching some terminology, so from using individual user to individual, switching from using PHI or PII to HSSI. And we wanted to note that PHI and PII are substantially defined as the same, or are substantially the same as the HSSI definition under the DXF. So this is not an administrative change or more than an administrative modification. They're also replacing a reference from a governance entity with a reference to CDII, because CDII is responsible for the relevant portions of this PMP. And a few other more minor changes that are included in the slide for people to review. Okay, so moving on. We have about 13 minutes left, but I think I can get through all this. We wanted to report out on the Implementation Advisory Committee meeting that happened about 2 days ago. They gave us an update on the DSA signatories. So far, we have 1,250, representing over 1,900 different entities. And CDII did communicate that they estimate that this represents about 30% of the total required signatories. So there is still a way to go, but there is higher representation among certain types of organizations that CDII is tracking. During this meeting, there was also discussion around QHIO expectations and annual attestations, and how CDII should respond if, and how CDII should respond if the QHIOs fail to meet future commitments. And then there was also discussion around the two PMPs that are currently under development. So I will quick go into what those summaries are. So in relation to the data elements to be exchanged PMP, which is currently being amended, advisory members were generally against allowing for the continued use of legacy formats, terminologies, and data standards for existing point-to-point connections. And they heard that delaying compliance might discourage interoperability in general. And organizations will be allowed to use legacy connections into 2024. So allowing this use will not really help with exchange during a delayed compliance period. There was also comments that there was support for establishing a precedence for data elements, terminology, and data format standards. And the advisory committee members also shared that they were overall against additions for allowing exchange of claims using alternative standards, since the named standards included do not support claims. And I'll quick move into the next PMP that was also discussed. Let me move that slide forward on the participant directory. CDI heard that participants should be in charge of their own choices and updating their preferred methods to exchange, but they should consider allowing delegates or allowing delegation to their intermediary to keep this information up to date. Participants should also be able to specify their choice for point-to-point connections along with their intermediary selections. There was also comments that it's important to allow participants to use different entities for different types of exchange. Participants should not allow different or should not specify different entities for different required purposes. Additionally, participants should not be required to include more technical details like the URL endpoints in the participant directory. And there was also support for including technical contacts to reach out to for each exchange entity, and along with concerns around security risks. So let me pause here before I continue moving forward. Would anyone like to share any comments on the two PMPs that are currently under development?
So the timing of this is that these will be out for public comment, and we will have a subsequent conversation around what the Connecting for Better Health response will be.
Perfect. Thank you, Timmy, for clarifying that. And finally, we did go through and summarize the comments that have been received already for the requirement to exchange SSI, and then also the privacy and security safeguard PMP, where CDI received over 100 comments back in September for these. We did compare and consolidate the different comments received into two tables. In general, there was a lot of alignment on this first PMP, the requirement to exchange SSI. But does anyone want to have any questions or want to discuss things more deeply before we move on to the next table?
No, I just think this is really a great value add, because if you look at all the comments, it's a lot to be able to pull together. So thank you for the cheat sheet, Olivia. And it also helps to zoom in on, what folks are thinking.
Perfect. And then we also did the same for the privacy standards and security safeguard table as well, all the comments. There were a few more concerns in regards to safeguards, but we're looking forward to what CDI has to put out in response to all these comments. Perfect. So now moving into our news, events, and announcements. We want to first start by, just bringing awareness to recent Connecting for Better Health publications. And so new ITEP DXF, they have a new DXF fact sheet and a policy toolkit with a lot of really great quick links to help you, navigate to what information you might need on the data exchange framework.
Connecting pause on that, because I keep going back to it. And this is the work that came out of the CDII data sharing framework grant that Connecting for Better Health leads with APG and Transform Health. But I keep going back to it over and over. And for all of you, if you haven't looked at the policy toolkit, please connect to it, put it up in your bookmark, because it'll really help all of your constituents and members that you represent and partners that you work with. If and when you are talking to anyone who is not familiar about the data sharing framework or the data sharing exchange, go to these two pieces. They're fantastic. If you don't go to our website, go to these two pieces. So thank you, Olivia. I just wanted to really put an exclamation mark. I'm sending them out left and right. And thank you to our ITEP partners that really pulled this together in such a meaningful and easy to digest way.
Yeah, I could not agree more. I really enjoyed the CAR visualization to kind of help understand all the different pieces of the data exchange framework and how they all fit together. We wanted to also call attention that the California Health Interview Survey, CHIS data for 2022 has been released. There have been a lot of great insights on, for example, California had its lowest uninsured rate, at least with what CHIS has been recording in 2022. And there are more gains to come in 2023 and 2024. So we're excited to see what insurance looks like moving forward. And there's also a lot of great insights on telehealth, behavioral health, access to care, lots of great information. So please dig into that.
And we had the CHIS leader, was it a month ago or so, that presented on the work
yes.
there. And my big takeaway there was this is a big inroads with public health, and where and how you can take a look at what they're seeing. And then maybe for those of you that are HIEs and have an analytic platform, take a look what you're seeing, and where and how can we really marry these insights together to get a real feel for what's happening on the ground.
Next, if you're not signed up already, we'll drop the link in the chat, but please sign up for our newsletter. We keep everyone up to date on what the coalition's been doing and also, what's up in the news. There was a recent blog post or a blog shared by industry initiatives with Blue Shield of California on the potential of the data exchange framework to help reform prior authorizations by expediting decisions, improving the accuracy of those decisions, and strengthening overall transparency and accountability. There was also a recent announcement that the federal joint HIE, which has data from the DoD, the VA, and a few additional federal departments, they recently joined Care Quality and now have access to over 90, or can now share data with over 90% of US hospitals, which will help support veterans as they navigate care between different systems. Again, we also highlighted the CHIS data release and a couple of those findings in our newsletter this week. And we also wanted to call to attention a data sharing pledge that 13 major health systems, including Kaiser, UC Davis Health, Stanford Health, and a few others that have entered into this data sharing agreement with the VA to improve care for veterans. And everyone's had a very busy fall, and there's a lot more to come with upcoming events. Connecting for Better Health will be at CAPT next week, I believe next week or in a week and a half in Palm Springs. So, please join us. We are having an after hours event that I think is on our next slide on the Monday night. So that we're hosting with Manifest MedX and Unite Us. So we are excited to have data conversations with our partners. Also, APG's annual fall conference is coming up end of October, early November. There are more data exchange framework policies and procedures. The subcommittee's meeting at the end of October. And I don't believe I have it on here, but the implementation and advisory committee is meeting again in November as well. We also have the California Telehealth Policy Coalition and eConsult Work Group. Their annual meeting is in Sacramento on November 8th. And there's going to be a lot of great thought leaders presenting there. So if you're interested in telehealth and digital health, definitely highly recommend that one-day event. And I also want to call attention to the Community Clinic Association of Los Angeles County. They have their 4th annual Health IT Summit coming up in November. And additionally, the California Association of Health Facilities, they have their annual convention coming up to mid-November. So lots to pack in before the end of the year. Here's more information about after hours at CAP coming up. We'll share the RSVP link in the chat, but it's going to be a great event with a lot of great thought leaders. So definitely, come hang out with us and let us know if you'll be there. And finally, we do have a couple slides on the DSA round 2 awardees for the grants, so you guys can check them out in the slides. But Timmy, I'll hand it over to you to wrap up. We have 2 minutes left.
Wow. Well done, Olivia. And in the chat too, some great feedback that this is just really helpful to be able to get grounded on all this work that's happening. And, we all need to be really thoughtful about reviewing the policies and procedures and how the data sharing agreement is evolving. So we'll continue to keep that focus. Reach out to us, and we'll see. Our next meeting is in 2 weeks, I believe. And also I put in the chat just real quick that the California Telehealth Policy Coalition and the eConsult Work Group, our annual summit, is hosted in person this year. We were hybrid last year. We're in person this year, but it's also a terrific way to track telehealth policy and the eConsult work with access to care that we continue to evolve in the state. So if you have interest or you think your organizations have interest, please join us. And I think that's it. Thank you very much for joining us today. And we'll speak soon. Take care.